With utmost pleasure, I would like to introduce the faculty for today, Dr. Rajani Surendar Bhat, who is a consultant physician pulmonologist at boardofdoctors.com. She has completed residency in internal medicine and fellowship in pulmonary diseases and critical care medicine at the Albert Einstein College of Medicine, New York. She is an elected member of the Governing Council, Indian Association of Bronchology. She is a mentor for the Death Over Dinner, India. Her areas of interest are in interventional pulmonology, ILD, medical humanities, palliative and end of life care, burnout prevention, death literacy, communication sciences, healthcare activism, medical law, and ethics. She is active in the field of education, research, and implementation of best practices in palliative pulmonology in India. So, thank you so much, ma'am, for joining today's session, and over to you for the session on respiratory symptoms.
Thank you so much for the kind introduction. And I realize that I need to update my the CV with Pallium India. Are you able to see my screen?
Not yet, ma'am. If you have started screen sharing, we are not yet able to.
Not yet able to? Okay. So as of now, I just wanted to share an update. I am now a consultant with Sparsh Hospital, which is it's a multi-specialty tertiary care hospital in Bangalore. And in the interim period, I've also got my fellowship in palliative medicine from NFPM, and I've also done a specialization in neuro-palliative care. Completed my diploma in medical law and ethics. So, the entire drive for this has been really I think the inspiration has been from seeing how difficult our patients' journeys are and the caregivers' journeys are, and how can we upskill ourselves and improve our ability to support them better on these very difficult journeys that they take. Thank you very much to Pallium India. It's always a pleasure to come back, and I'm always energized by each new cohort of new champions in palliative medicine who are taking it up, as I see on this course as well. Wonderful to meet all of you. And I heard Sri Priya say earlier that you can always reach out to people who are coming as faculty on this program, that if there's anything specific that we can help you with, share our learnings with you, we're more than happy to. With that, I'll move on to my talk. Apologies for the late start. Are you able to see my screen now?
Yes, ma'am.
Okay, perfect. So what we'll try and do is just look at the scope of, respiratory symptoms is what it said, but we need to understand that respiratory symptoms can come up in respiratory diseases as well as non-respiratory conditions. And it has a significant burden that it places on patients and their caregivers. So we, as in India, are home to 18% or nearly 1/6 of the world's population. And we are home to almost 1/3 of the world's population that suffers with some amount of, loss of quality of life due to chronic respiratory disease. So we are disproportionately affected as a population with chronic respiratory disease. We know now that COPD is the third leading cause of death in the world. This is one of those chronic insidious diseases where the 5-year survival is more than 70%, which means that our patients actually live with difficult symptoms for a much longer period of time. TB is a huge problem in India, specifically drug-resistant TB the world over. We just witnessed a pandemic, but TB is a pandemic that's been around for over a century. And we still haven't managed to address many aspects of the discomfort and the distress and the painful symptoms that patients experience, specifically when it comes to drug-resistant TB. It's not just the toxicity, it's not just the symptoms of the disease, but the toxicities of the treatment. When we look at how well do we address palliative care for patients with respiratory disease, if we look at some mature systems where there is nationalized healthcare, where the concept of palliative medicine and end-of-life care has been part of a national health system for a long time. This is a study from a Swedish population-based study. It looked at a comparison between COPD patients and cancer patients. And you realize that patients with COPD have a lot of symptoms, breathlessness, anxiety, pain, nausea, but they are not given medication for these same symptoms, which patients with cancer actually find that their symptoms are addressed better. So we find that COPD patients receive a lower quality of care for symptom control compared to cancer patients. That is expected in all these patients with advanced diseases. The cancer patients have counseling, home care, palliative care services, end-of-life decisions are, supported by their doctors. And this is again the same study, Swedish population-based study. Same way for COPD patients, if you look at it, same kind of conversations did not happen. The same kind of support was not available. Patients were more likely to die in hospitals. Patients were more likely to die in ICUs. So clearly, we are not recognizing the heavy symptom burden that patients with respiratory disease have. So when we look at what kind of palliative care is necessary for patients with respiratory disease, I have only spoken about two of the large burdens that are there when we think of respiratory diseases. One is COPD and one is tuberculosis. So you have palliative care within respiratory diseases for respiratory symptoms, that is the breathlessness, the cough, things like that. And this could be related to cancer or non-cancer diagnosis. It could be lung cancer. It could be metastatic disease to the lungs or pleural effusions, or it could be non-cancer diseases like COPD and ILD, which have breathlessness, cough, and similar symptoms. We also have non-respiratory symptoms in advanced respiratory disease. We recognize that patients with COPD have a lot of anxiety, depression. They also have symptoms like pain. Pain is highly unaddressed in a COPD population. They have pain, they have GI symptoms, they have sleep disturbances. All organ failures in the end will lead to breathlessness. You think about an advanced cardiac disease, end-stage heart failure, you think of end-stage renal disease, you think of end-stage liver disease, you think of neuromuscular diseases and neurological degenerative conditions. They all end with breathlessness. And all end-of-life decisions and discussions will involve relief from breathlessness. So this is an important area that we must learn to be familiar with, right? So when we look at the respiratory symptom complex, there is the breathlessness, the evident one. Hypoxia, you may be breathless without being hypoxic. You may be hypoxic without being breathless. How much is hypoxia contributing to your breathlessness and how much does that need to be addressed? Cough is the third most common symptom for any doctor consultation across the world. So you look at outpatient clinics, your general practitioner, your family physician. Across the world, cough is amongst the top 5 common symptoms that people seek care for. Those coughs are usually short-lasting. When you have a patient with a chronic respiratory disease, this cough is incessant, relentless, and it really disturbs their quality of life. It's exhausting, it's painful, it's disturbing, not just to the patient, but to the family. Secretions, mucus coming out. You have patients who have bronchiectasis, you have patients who have lung abscesses. They are terribly distressed by the volume of the secretions. And if their cough reflexes, if their cough is inadequate, then with the sensation of drowning with secretions as well. One of the most dreaded symptoms of hemoptysis, very scary if you're coughing up blood. When these things go on further, you have other symptom complexes that come up, which is respiratory failure. You might have pleural effusions, which can be because of lung conditions. It could be because of heart or kidney or liver conditions as well. You can have airway obstructions. You can have tracheal stenosis, or you can have growth in the airway. And that causes a sensation of suffocating, choking, because you only have one single way in which you can breathe, the trachea. And if that gets blocked, it's one of the most scary sensations in the world. And we spoke about associated symptoms as well. All the symptoms that patients with respiratory disorders can experience: pain, nausea, constipation, anorexia, muscle wasting sarcopenia, sleep disturbance, dry mouth, anxiety, depression. And as these symptoms progress, as the disease progresses, their life starts shrinking down slowly from when they are ambulant and walking out in the world, carrying on their roles, whether it's professionally or as a student or as a caregiver, whatever it is, they're playing a role in life. Their role in the world and their world starts shrinking down from being out in the community to being able to being housebound, to finally being bound to just a room, to finally being bound only to the bed. And very often, this can also be accompanied by feelings of guilt because some of these patients have chronic respiratory conditions which may have an association with smoking. So they deal with a lot of guilt, either due to whether there was the etiology of the illness was associated to one of their lifestyle choices or decisions. And they also face guilt about being a burden to their families. And what ends up happening when they go to a doctor is that we've been inadequate in the field of palliative pulmonology or management of respiratory symptoms. The management of pain and many other symptoms has had a head start of over 40 years on us. If you look at the literature in palliative medicine from the 1950s, 60s to now, which is 2024, it's like a 70 plus history in terms of literature and research. When I started my pulmonary and critical care training, at that time, if I picked up a palliative medicine textbook out of a 7,000 page volume, I would find one chapter with maybe 120 pages that would be, or even less, that would be about respiratory symptoms, and everything else would be about all the other symptoms. So the literature in breathlessness cough research has really shot up in the last 10 to 15 years. And this is a good thing because it means we're starting to address that breathlessness is a very important symptom. And it's not something that must be taken lightly. It is something that impacts quality of life in a big way, not just for the patient and the caregiver. And we've developed ways, there's robust evidence to support the role of integrated palliative medicine services for all patients with chronic respiratory conditions. So let's do a little exercise. I'm going to ask all of you to just find a comfortable seated position. Okay, and you're going to do a breathing exercise along with me. I hope you can see my hand going up and down. This will be on one side of your screen. So when I say take a deep breath in, I want you to fill up your lungs all the way to the top. And then when I say breathe out, all the way out. Breathe all the way in, all the way up to the top. Breathe out, all the way down. Take a deep breath in, all the way in. Hold at the top of your breath. Deep, breathe only 1/3 out now. All the way back in again. Only 1/3 out now. All the way back in again. Only 1/3 out now. All the way back in again. Only 1/3 out now. All the way back in again. Now you can breathe normal. Just take a few relaxed breaths up and down. Slow and easy. Take a deep breath in. All the way out to the end. Only 1/3 of the way in. All the way out. Only 1/3 of the way in. All the way out. Only 1/3 in. All the way out. Only 1/3 in. All the way out. And breathe normal. Just relax. Take a few calming breaths. Shake your head from side to side. Roll your shoulders back. Would anybody like to share what that felt like? Any of you would like to unmute yourself and tell me what it felt like when you were breathing right at the top, right at the bottom, or just in the middle? Any difference that you experienced? So we'll take 1 minute, 30 seconds for some feedback on what this felt like.
Uncomfortable.
Uncomfortable. Yeah, it felt uncomfortable. And we were just sitting. Any other thoughts? Were you thinking, when is she going to stop this exercise? When can I breathe normal? So imagine that sense of discomfort is what we experienced over maybe 10 breaths while we were seated at rest in a comfortable position. If you had to experience that, walking to work, climbing upstairs to the doctor's office, going to drop your child off to the bus, school bus, going to the bathroom, thinking, oh my God, I'm not going to make it Urine's going to leak out. I'm not going to make it in time because I'm so breathless that I might pass out. Now, that is what our patients with chronic respiratory disease experience day after day, week after week, month after month, year after year, for years on end. So imagine a person, when we were saying right up at the top, that's an emphysema patient who has hyperinflated lungs and their diaphragm is not able to come back to resting position. They're breathing right at the top of their lungs. And that all the way down there is your ILD patient, shrunken, fibrosed, frozen lungs, which can only breathe that much. So that gives you an idea of their day-to-day discomfort. Now, breathlessness is basically this. We've all experienced it at some time or the other. We've run for a bus, we've run for a train, we've run because we're late for a lecture or an exam. But when we stop at the end, when we reach our destination and we catch our breath, we take a few deep breaths, we are able to bring it back down. So by a little increased effort, my discomfort is relieved, my increased demand is met. When it is not met, then the fear that comes in is, oh my God, I'm going to die. So when we talk about pain, we talk about the worst possible pain, I'm going to pass out. When we talk about the worst possible breathlessness, it comes with a threat to survival. It comes with a threat to life. I feel I'm going to die. So it just completely messes with every part of your, higher functioning, cognitive, functions of being able to, your executive function goes out of the window. So when you're breathless and you have to do multiple other things, it really becomes very, very challenging. So this was just a little exercise in, learning how to understand what a patient experiences. So when we think about dyspnea, we have to think of all the emotions that come on when a patient is experiencing dyspnea. This is happening in a certain physical context of their disease. It may be happening in a certain way, whether they're in their own home or they're in a space which is in the public, and whether they have help accessible to them or not. It is influenced by age, it's influenced by hormones, by gender, and it causes all of these cognitive problems as well, right? It takes up all your attention. All my focus is on being able to breathe. I am not able to receive inputs that people are telling me. It's hard for me to make decisions. All of it is about just being able to breathe. And therefore, I will slowly start taking myself away from situations which may trigger that sensation again and again. Every moment of breathlessness will reinforce this feeling. What ends up happening is I start getting housebound, I start getting bedbound, I'm moving less, right? So my muscles are now getting deconditioned. So overall, it becomes a bad, vicious cycle. So just like you are probably already familiar with the concept of total pain having these dimensions of physical, psychological, social, and spiritual. Similarly, you could apply that framework to breathlessness and respiratory symptoms, where it has all of these elements in how it affects you and your functioning as an individual. So my interest in palliative pulmonology came about when I read this trial. It was really a landmark moment for many of us, that when we realized that an early intervention in breathlessness support services can make such a big difference in patients' lives. So for the longest time, palliative medicine, breathlessness support services, palliative pulmonology has been thought of as a desirable but not an essential part of the management of respiratory diseases, right? Because we're just looking at it as offering comfort. But this trial looked at, it's agreed the numbers are small, but you had patients randomized to receive, these are patients on oxygen who were COPD, ILD, or cancer patients who are on oxygen, who were either randomized to standard of care or who also had breathlessness support services offered to them, which was an evaluation where they were taught about how to cope with breathlessness. They received phone calls from nurses who were trained in breathlessness support services. And when they looked at these patients, years on, they found a survival benefit of the early intervention of breathlessness support services, which is a palliative medicine intervention. Similar studies exist when you look at early palliative medicine intervention in lung cancer. When you have early palliative medicine intervention in lung cancer, those patients actually have survival benefit. So if this was a drug, every doctor would be prescribing it. Why is it that we're still not doing it? One, the medical community itself has not understood the implications and the survival benefit that comes with it, as well as the quality of life benefit. Two, it's labor intensive and not monetarily not remuneratively as attractive to the private healthcare structures that we have. But this is important for us to know, so we know the value of our work. It's quality of life as well as a survival benefit. So you're not just adding life to years, you're also adding years to life. These patients who were in the breathlessness support services group had fewer hospital visits, fewer ER visits, had better advanced directives, had the end of life at home. So every possible quality of life benefit also came through for these patients. So when you look at dyspnea management, there's aspects to it which are non-pharmacological, and there's pharmacological aspects to it. Alternative therapies we don't have as much evidence for, but it's not that it could be offered in special cases to patients. Pulmonary rehab, physical rehabilitation is one of the most important aspects of breathlessness support services. Our goals vary depending on where the patient is in the disease trajectory. When they're early on, we are trying to improve their functional condition, trying to improve by strength training their capacity for exercise. Later on in the disease, the same exercises are titrated down to submaximal effort so that there is symptom relief and maintaining quality of life of at least mobility and things like that. Oxygen, non-invasive ventilation. For a patient who has hypoxia, oxygen adds value because it allows them to maintain a certain amount of functionality. So if you have a drop in your oxygen saturation when you walk, then using oxygen will allow you to walk more. So our main goal with all our patients is to be able to keep them ambulatory, maintain their nutrition. So that's where it helps with non-invasive ventilation, BiPAP, for those patients who have carbon dioxide retention, CO2 retention, type 2 respiratory failure. Home BiPAP is also an option where they use it intermittently in the daytime and all night long at home. One of the least used but most effective non-pharmacological interventions for a patient with breathlessness is a handheld fan. So you have a simple fan. It can be one of those rechargeable or a battery operated fan. You can buy them off any website these days. A fan which is held about 15-20 centimeters away from the face. So you moisten the face with a wet towel, and then you blow a fan at your face when you're feeling breathless. What this does is it stimulates the sensory nerves of this area, which sends a stimulus to the brain saying that I am getting enough air. And that entire hypervigilance, hyperventilating, anticipatory breathlessness part of it starts coming down, right? So then you're able to regulate your breathing better. When non-pharmacological means are not working, that's when we have refractory breathlessness, and that's when opioids and benzodiazepines come into play. Alternative therapies that have been used for breathlessness have been music therapy, have been mindfulness meditation techniques, guided meditations, progressive muscle relaxations, all of that. In mindfulness meditation, the part that we usually prefer for patients with breathlessness, mindfulness meditation has many different types. You have breathing focus, or you have sensory awareness. For patients with breathlessness, since focusing on their breathing may actually increase anxiety, we work more on sensory awareness as a mindfulness practice, or certain repetitive activities. So that's where sometimes the spiritual belief or faith-based beliefs of patients come in, because chanting, faith-based things like hymns and chanting can help a patient to take their mind off the sensation of breathlessness until the interventions, whatever for the disease. Like if I have to give a nebulization, I have to turn the oxygen on, I have to turn a fan on. In that much time, if the patient develops a practice which helps them to calm themselves down, that helps a lot. So these are the modalities we use for chronic breathlessness syndrome. So breathlessness, this is the kind of breathlessness where you have disability despite optimally treating the underlying pathophysiology, right? So as we have understood more of the breathlessness pathways, about the fact that even with breathlessness, you have a similar thing with chronic breathlessness. You probably studied how it is different for acute pain versus chronic pain, anticipatory pain for some patients. Similarly, there's acute on chronic breathlessness, there is anticipatory breathlessness. So if I tell a patient that, oh, you've got to start exercising now, your rehab is coming now, they might already start feeling breathless. right? So for patients who have chronic breathlessness syndrome and who still need to go on with rehab to maintain functionality, sometimes in order to improve effort tolerance, learning to live with breathlessness, mastery of breathlessness, we will give them a small dose of opioid. So 5 to 10 milligrams of morphine before the planned exercise will help alleviate the anticipatory breathlessness, allow the patient to be ambulated better. So it's important to understand how the patient experiences that breathlessness. What is it meaning to them in their life? How does this breathlessness affect me? How is it shrinking my life down? What are the things I used to like to do, which I can't do anymore? This allows them to also set goals that we can work with when we are teaching them, when we are training them in the chronic breathlessness management symptoms, right? Awareness of breathing patterns. You will be surprised when you work with patients how unaware sometimes people are of the very simple basics of inhale and exhale. So I'm going to tilt my camera down here, but we usually try and tell them to place a hand on their chest and one hand on their belly. And we ask them to learn how to do abdominal breathing. When they take a breath in, the belly comes out, and exhale, belly goes in. This understanding of abdominal breathing, belly breathing, inhale versus exhale. Sometimes they're not able to figure out when I tell them to inhale, they'll actually blow out. So I'll use techniques like taking a straw and keeping a little liquid and then tell them that this is the action you do for an inhale, and you keep a little thin strip of paper and say, blow on it, and that's the action for exhale. So you have to try and tell them through different things how to build back awareness of their breathing patterns. Pacing and positioning is very important to maintain functionality. Young people lead busy lives, active lives, sudden disease, which brings about breathlessness, or someone who's been a very busy individual, the matriarch of a family who's been running, taking care of so many people in the family, suddenly gets afflicted with an interstitial lung disease or something. And, she is not able to slow herself down because she's used to be working at that pace, walking at that pace. And you have to teach them to pace themselves slower. So walk a little bit, do some pursed lip breathing, gather your breath back. So pacing and positioning, handheld fans, again, as we said, distraction, pulmonary rehab. Then I come now to the breathing, thinking, functioning model. This was developed in at Cambridge by Dr. Anna Spathis' group, Sarah Booth, who have been pioneers in breathlessness research. And it basically looks to address what happens during that experience of an acute attack of breathlessness in somebody who has a chronic lung condition. So there's the breathing element, which we were talking about, lack of awareness of how you are breathing. So there's inefficient breathing. When I'm getting breathless, I'm inhaling more and worsening the dynamics of my breathing. And your accessory muscles are being used. There's dynamic hyperinflation. And what we actually teach them to do is a more efficient way of breathing, which is breathing out, pursed lip breathing, breathing in a rectangle, focusing more on exhalation, using a handheld fan. These are ways to get the control of breathing back. It only works if you have practiced it when you are not breathless to be able to deploy that technique when you are acutely breathless. So they need to be trained in these techniques while they are comfortable sitting so that they can deploy it when they have to move and climb stairs. Thinking, what happens when you're suddenly breathless? All these thoughts come in like, oh my God, I'm breathless again. Okay, let me take my inhaler. I'm still feeling breathless. Okay, I'm calling my sister, please give me my nebulization. It's not working. What's happening? I'm going to end up getting admitted. I don't want to go to the hospital. I'm going to want to end up in the ICU. I don't want to end up on bypass. So see the catastrophizing that starts happening. I got admitted 3 months ago. That has scarred me in a way that the next time I experience an attack of breathlessness, my mind is straight away going to a place where I can't think of anything else. I'm not able to focus on my breathing technique at all. So being able to give them a way of addressing that. So sometimes that is just by telling them, as we said, fixing onto it's even environmental design can help us over here. So there's a concept called biophilia, which is, as human beings, we are drawn to things that represent nurturing nature, life preservation, things like that. So sometimes keeping a picture, an image of a seaside, with a mountainside or forest or flowing water, things like that, help us to calm our mind down, as long as you've practiced doing it. So you know that you teach them the breathing technique, focusing on an image. So the next time they look at the image, it allows them to again calm their breathing down. Another thing is to develop a chant and a mantra which says, I've been through it before. I got out of it. I can do it again. This has happened to me before. I know how to manage it. It will get better again. So that all is well kind of thinking, right? Instead of the catastrophizing cycle, we come into managing the anxiety and saying, let me calm my thoughts down enough to actually deploy the methods available to me at hand. The functioning part of it is to learn to live with breathlessness and not reduce activity, right? So that is the mastery of breathlessness. Breathlessness may not go away 100%, but if I can reduce it 50%, I can still be walking. I will learn how to go to the bathroom on my own. I will learn how to take a bath on my own or with minimal support. I will learn how to do these things in a way that I'm still maintaining contact with the outside world. Because if I reduce my functioning and my muscle deconditioning worsens, then the breathlessness will worsen, then the accessory muscle use worsens, then the pain and everything else worsens as well. So this is how we look at the breathing, thinking, functioning model for each patient. Each time you meet them, you try and focus on which area you can develop. And then in each episode, they will find a tool that they can use in order to bring their breathing back into control. This is just a recap of the previous one. These are some images of positioning. We spoke about pacing, which is, if I have to walk from my bed to the bathroom, if I usually walk in one shot, maybe I want to, the first impulse that I need to go to the bathroom, get out of bed, start walking slowly, pause 1/3 of the way, take 3 breaths, make sure that the breathlessness is under control, walk another 1/3 of the way, pause, take another 3 breaths, walk all the way to the bathroom, pause, do my business in the bathroom, pause, come back again with two or three breaks. It might take me 3 to 4 minutes longer, but I have not got more breathless. I am not more anxious. My saturation has not gone below a level which triggers panic for me. Similarly, positioning. When you feel breathless, we teach patients to learn to find the right position. When they are standing, what can they lean on to help them be in a more comfortable position? When they are sitting, what is the position that they can adopt to alleviate breathlessness? In a supine position, side lying, slightly propped up, all of these are the positions. Important that if they have certain conditions, that they know the medications to be used. So if a patient has heart failure, we teach them to monitor their weight, see the pedal edema, and use their diuretic to optimize their volume status. If they are patients with an obstructive lung disease, then when you're acutely breathless, it's probably better to use a nebulizer versus an inhaler. So in an acute episode, it's hard to take in a breath and hold it for the inhaler to be effective. So at that time you use a nebulization, but the rest of the time when they're okay, the inhaler is equivalent to a nebulizer. Theophyllenes and methylxanthines, we don't use except in very advanced COPD. That is not the drug of choice. Steroids as needed for asthma COPD exacerbations. If a patient has an actual airway obstruction and stridor, they will need advanced evaluation. This will probably mean an ENT evaluation or an interventional pulmonology evaluation. Some of these are chronic conditions, and these patients can benefit from non-invasive ventilation if it is something like a tracheomalacia, or they may need a procedure like a bronchoscopic procedure. So airway stenting is a way of alleviating airway obstruction. This is for patients who have central airway tumors, tracheal tumors, bronchial tumors, which are invading into the airway. Oxygen we mentioned earlier. There's multiple ways of delivering oxygen by a nasal cannula or a face mask. By a nasal cannula, you can give up to 4 to 6 liters per minute. Otherwise, it dries out too much. Beyond that, we prefer to use a face mask. The flow can be from 6 to 10 liters per minute. Keep in mind that when you're using the face mask, again, some patients may feel claustrophobic with this area blocked off. So if it is better for a patient, if it's a patient with chronic hypoxia who usually runs a little low saturation, I don't mind using nasal prongs and a fan when they are breathless. So the goal saturation could be anywhere. My goal is let's just get to 85 to 90%. It doesn't have to be at 95%, but let's get the breathlessness under control over there, right? A non-rebreather mask when higher flows of oxygen are needed. This is usually in an acute inpatient setting. Similarly, looking at the inhaler devices, there is a mask nebulization, there is a mouthpiece nebulization, and these are the half-puff kits for children. The mouthpiece nebulization is something, again, for patients who feel claustrophobic. Now, you have a COPD patient who's wheezing, and then they keep pulling their mask off when you're trying to give them a nebulization, saying, I can't breathe when you put the mask on. And you think that's paradoxical because you are giving them a medication, which is a bronchodilator, but they're pulling it off. So if you gave it to them through a mouthpiece and had a fan on their face, they would accept it much better. So this was what we addressed about hypoxia and hypercarbia. Oxygen concentrators and portable oxygen units. It's important that we still try to maintain mobility. So asking the oxygen provider to give you a longer length tubing so that the patient can walk around. In terms of oxygen use, sometimes patients will think of it as an, will be hit very hard by the fact that they need to be on domiciliary oxygen and need daily oxygen use. And they don't want, they again get into the isolation mode of not going out. And you tell them that oxygen is actually a way of, it's not an indicator of disability. It is giving you the ability to maintain a quality of life. It is giving you the ability to maintain a social life. It takes some amount of understanding what their concerns are. There may be cosmetic concerns, they will say that, I don't want people to see me with this tube. It's very similar to when you look at disability and the use of a wheelchair or a cane. So you frame it in that same way, that this is an accessory that allows greater ability and quality of life. And each individual patient will have their stories, their hooks, which you can use to help them to accept the oxygen better. Cough, a very unpleasant sensation. Moving on to another large symptom area. I'm going to try and cough. We don't have too much evidence for too many treatment modalities for cough. I will say one thing, most cough syrups are not useful in any chronic cough situation for patients with advanced respiratory disease. So I see so many prescriptions of so many cough medications and so many combination medications. Please know that for your patient who has chronic cough over weeks, months, years, these cough syrups, especially the combination formulations, can also give a lot of side effects. There's gastritis, there's GI upset, there's tremors, all of that comes in. So the main thing for cough would be to address what is the etiology of the cough. So cough, again, is another part of respiratory symptoms, which we have got greater understanding of only more recently. There is a pathway of stimulation of the cough, the receptors for the cough reflex. It could be based on stimulation in the upper airway, or it could be in the lower airway. It leads to a forced exhalation for attempting to clear secretions. When we do those forced exhalations, there's a lot of force that's generated in the lower ribs, the intercostal muscles, as well as the abdominal muscles, which are the primary muscles of expiration. So patients with an incessant cough have a lot of pain in their ribs. They may develop rib fractures. They may develop vertebral fractures. They may develop little muscle tears. They call them side stitches, and it's extremely painful. So it's important to address the symptom of cough. Some of them will have cough which lasts all night long. It disturbs their sleep. So it's very important to understand the etiology of the cough to find out what is causing the cough. Look at all contributing factors, whether it's acid reflux, a postnasal drip. And the treatment is demulcents, antitussive agents. So demulcents are those things which create a nice sticky layer. So those are your dextromethorphan lozenges, your grandma's remedy of taking honey and turmeric and a little ginger juice and licking it. That's basically a demulcent agent, which creates a little protective film, which doesn't allow the mucosa to get very dry and irritated. For these chronic coughs that our patients with ILD have, of late, there has been some evidence for gabapentin. There is a new drug which is coming out. It's available, I believe, in the UK and Japan. It's called gefapixant. It's one of the first new drugs for cough that has come out in decades. There is some evidence for, as I said, for gabapentin, very little evidence, some minimal evidence for baclofen and ILD cough. Opioids, even though the evidence is not very strong, have been used over the decades for cough and do cause a little reduction in the frequency of cough and can help in some relief. There's also been some evidence to suggest that the antifibrotic treatment, which is nintedanib and pirfenidone for interstitial lung disease, also over time, these are for the chronic patients who've been on it for more than 1 or 2 years, has led to a slight reduction in the cough frequency. There are some patients where it's mainly an upper airway cough, and there's a psychogenic element to cough. Cough is partly involuntary, partly it is voluntary. Part of it is how we are sensing the hypersensitivity of the mucosa to the stimuli. So speech therapy helps a lot in reducing the frequency and intensity of cough symptoms. And there is no routine recommendation for use of PPIs unless you have proof that the patient is experiencing reflux symptoms. So if you have a patient who, the minute they lie down, they're experiencing cough, then you would say that, okay, this patient would probably benefit from a PPI. That's basically it. When it comes to secretions, you have to look at what is the cause of the secretions. One, is it oral secretions which are trickling down into the airway and causing cough, or is it actually tracheobronchial secretions, which is mucus from the respiratory epithelium, from the glandular part of the respiratory epithelium, right? So it could either be oral secretions trickling down into the airway, aspiration that's happening into the airway, or it's respiratory secretions, or it could be something else. It could be blood or something else, right? We look at the onset, provoking, and palliating features for the secretions, very similar to your pain assessment. Quality of the secretions. Where are the secretions coming from? Is it a drip down coming out of the throat, or is it something that's coughed up? What's the severity? And we need to understand what interventions are okay and not okay for the patient. This might seem unusual, but specifically for neuromuscular patients. So we have patients who have a neuromuscular disorder where cough becomes a constant problem because of aspiration, because of bulbar weakness. Knowing the values of the patient about whether a tracheostomy is acceptable or not is important here for the kind of intervention that you will advise for them. Therapies to promote expectoration of secretions. One is manual assisted cough. So we teach them breath stacking techniques where they go and then have an assisted cough with a family member or a caregiver giving them some pressure on the abdomen to help them bring out, specifically in patients who have restrictive lung disease because of kyphoscoliosis, neuromuscular disease, where the problem is not that the cough is more, it's because their cough is ineffective or they are unable to cough. So as much as there is a problem with reducing cough, dry cough, there is a problem with inadequate cough in patients who have a lot of secretions and aspiration. So there are ways that we look at addressing the inadequate cough. And towards the end of life, when there are a lot of oral secretions to manage, we will use agents like glycopyrrolate or hyoscine, things like that, for reducing the upper airway secretions. Okay. Some patients with chronic conditions may benefit from bronchoscopy just to facilitate clearance of secretions. Postural drainage is a very important part of secretion management. And this is done either by a physiotherapist, or we train the family members on how to do percussion at home after a nebulization to help the patient clear the secretions. These are the devices that are available. There's a cough assist device. The cough assist device, as far as I know, in India is available mainly for use in hospitals and ICUs. The flutter vest is not available here. We do have these are called mucus clearance devices. These are Acapella, Shaker Deluxe. These are devices which help the patient to loosen up the secretions, mobilize the secretions, and help to excrete them out. Again, some visuals of the devices I have mentioned earlier, the handheld fan. These kind of mobility devices are good. A walker with wheels, rollators, which help the patient to keep moving at home with some support and a little less effort on the patient's part. Some patients on constant NIV develop nasal bridge ulcers because of the pressure. So using a soft gel mask over the nose bridge prevents that from happening. So every little bit that you can make the intervention and treatment for the patient a little more comfortable, we try to add a layer of comfort for the patient. What about hemoptysis? That most scary of all symptoms. Main thing, cough suppression, stop all nebulization. You can treat the patient with tranexamic acid. It can be IV or oral. If the patient is curative intent treatment plan. So if it's a patient with some kind of malignancy and they have a tumor invading the airway, but the patient's prognosis is such that they are amenable to further treatment, whether it's chemotherapy or radiation, then we do send them forward for interventions. The interventions could be a bronchoscopic, a bronchial artery embolization, or sometimes it can be an airway intervention of a rigid bronchoscopy, tumor debulking, or airway stenting. If the patient is on a purely comfort care, palliative care pathway, where the curative intent is no longer applicable, then we try to reduce the discomfort related with the symptom of hemoptysis. So there we will bring into play use of anxiolytics and sedatives and opioids to relieve the distress that the patient is experiencing, and use dark linens to reduce the visual distress, not just to the patient, but also to the family and caregivers. Because that sight of red blood on white linens is very, very distressing. So anything you can do to reduce the anxiety, shift the environment to more in level of comfort for the patient and caregiver. Pleural effusions are a big challenge. We face recurrent malignant pleural effusions in all kinds of malignancies. Intercostal drainage can be done in some patients. So, sometimes it's repeated therapeutic pleural aspirations, pleural tapping. There are devices along with that can be used, which is called a Pleurex catheter if your patient can afford it. If not, an intercostal drain with a pleurodesis, which can be done with an agent chemical pleurodesis, either with medical grade talc or with betadine, is an acceptable solution as well. We also face pleural effusions in certain medical conditions, end-stage liver disease, end-stage heart disease, and kidney disease. And those actually are harder to treat than the malignant pleural effusions. So these were the methods that I was mentioning earlier. This is called a Pleurex catheter. The patient can be taught how to drain it at home. Some family members will be okay with draining it at home. Otherwise, the patient can come once in 5 days and get the fluid drained. So the patient doesn't have to be in the hospital. So this is a quality of life benefit. Patient can go home with a thinner drain, does not need to be in the hospital. Neuromuscular disease patients can have aspiration pneumonias. The decision about PEG is an important decision. When a patient's lung function starts dropping, when they start getting breathless on lying flat, that is definitely a time when we need to consider placing a PEG, because if they're not able to go all the way flat, then it's harder for a gastroenterologist to place a PEG. So it's important that if you have a patient with a neuromuscular disease where there's diaphragmatic weakness, where there's bulbar weakness, where there's respiratory muscle weakness, that you plan your nutritional support system early enough so that you are able to support the nutritional status before sarcopenia sets in. That would typically be when you have anything more than 8 to 10% of body weight loss, time to start talking about getting a tube in for feeding. Because if the patient is otherwise fully functional, other organ systems are fine, you can maintain a good quality of life if you prevent the infections, the cycle of repeated pneumonias and repeated infections, which really causes a downhill trajectory for these patients, right? So planning of the PEG, preventing aspirations in patients where we anticipate this is going to happen, requires a little bit of foresight, priming the patient beforehand. So we start talking about it, that this may happen in the future, then they are more amenable to seeking the intervention, accepting the intervention early. Always have an emergency plan for any acute emergencies. This may come up for patients, again, who have certain devices in place. So if there's a patient who's on oxygen at home, who's on a tracheostomy at home, the family should have a plan of how do we manage an emergency at home? When do we take the patient to the hospital? Who do I reach out to for emergency help? In patients who have advanced lung disease in an acute emergency, if we know it's a non-salvageable situation, but the patient's critically ill and does not want ICU and intubation, a high-flow nasal cannula is a good option for tiding over, even if you want to do end-of-life care in a hospital for certain patients where the nursing burden is high and they don't want to be at home, they would rather be supported in a hospital. You can support them with high-flow nasal cannula. Other important things to keep in mind for patients to, the nutrition element of it, high protein diets, fluid restriction, and appetite stimulants. These are important because it also helps in reducing the breathlessness. So if you're maintaining the nutrition adequately, then it helps to support the respiratory symptom control as well. Nausea, gastroesophageal reflux adds a lot to breathlessness. A bowel regimen is important because if my belly is bloated and my diaphragm is all the way up here, I can't breathe as well. If my mouth is dry, that really is bothersome, even in terms of breathing. So addressing that is important. In patients with respiratory disorders, it's still the same. You work your way up the WHO pain ladder and do not be afraid of using opioids if they are indicated. For a long time, people used to avoid using opioids in patients with COPD, saying, oh, it will precipitate a type 2 respiratory failure. But as long as you are going by the standard principles of start low, go slow, manage the nausea, manage the constipation, you will be okay. When it comes to managing patients with pain and breathlessness, whatever is your dose of opioid for pain relief, usually you need about 15-20% more of that to manage breathlessness as well. So that's your dose increase. If a patient has pain from before, already on an opioid, need opioid for breathlessness, that would be the slight increase in the dose. And incorporate every possible non-pharmacological means for pain management. Your physiotherapy, ultrasound, TENS, IFT, massages, all other alternative forms of therapy, so that your usage of opioids you are able to keep to a level where it's not concerning either for you or the family. Using nocturnal oxygen NIV is useful, but figure out when it is causing more discomfort to the patient. And if the goals of care become palliative, then we sometimes phase that out as well. We use melatonin and the judicious use of anxiolytics and sedatives. Even things like when we use gabapentin for cough, sometimes it ends up helping their sleep enough that they feel better rested the next morning. I'm going to skip this part about TB and just focus on the goal. So for the patient, it's really about getting over dyspnea. It's about trying to meet professional and personal relationship goals. So our goal in managing respiratory symptoms is really to look at global health-related quality of life for the patient and whatever we can do to facilitate that. Don't be afraid of using opioids. As we said, it has multiple benefits, reduces the urge, the sensation of, I'm gasping for breath, anticipatory breathlessness. These are the ways in which we use opioids, either for chronic refractory breathlessness. We usually, just for breathlessness, rarely need to go above 30 milligrams in 24 hours. So you can see that it's far less than what you use for pain management. Most of our patients will be okay with 5 to 10 milligrams every 4 hours or every 6 hours. For refractory breathlessness and for end-of-life care, we can even use infusions. I'm sure you'll be learning about subcutaneous infusions as well. So you can use infusions of opioids as well as benzodiazepines as needed for this. When do we initiate end-of-life discussions? There's a whole lot of scoring systems, but as a clinician who has followed up the patient, this is the most important thing. The surprise question actually performs better than most other objective scoring systems. Would you be surprised if this patient were to die in the next 1 year? And if the answer to that is, I would not be surprised, then you should start initiating end-of-life discussions with the patient. Definitely when they become more dependent on oxygen, when they have significant weight loss, if they've had more than one hospital, I would say 2 hospitalizations in 6 months, most definitely, yes. And if there's more organ system involvement, you need to find ways of broaching the conversation, especially if they've had an ICU hospitalization. I usually, when they come back in the OPD, will say, how was that for you? That must have been scary. What if it happens again? Have you thought about it? Are you okay with going back to the ICU? Have you thought of any other way that this could go? And sometimes they'll say that, my mother-in-law had a very severe problem. She was in the ICU for a long time, and I really didn't like the way that happened for her. She was on a ventilator. We were not right next to her. I would not want that to happen to me. So you will find ways of bringing it into conversation to understand what their thoughts, beliefs, values, preferences are. Alongside the patient is a very, very stressed out caregiver. So there's a lot of burnout that caregivers experience, especially of patients with respiratory symptoms, because they have to manage a lot of devices. There's nebulizers, there's BiPAP machines, there's this machine, there's that machine. They learn how to manage all of that. So please also pay attention to the caregivers. And yeah, sometimes you may not see progress, but as long as you can help them to breathe a little easier on most days of their lives, enough to find one moment, which means, I had some good moments today, then you're doing your job well in terms of palliating respiratory symptoms. I'm going to finish with a simple breathing exercise for all of you. So again, I want you to find a comfortable seated position. And this time we'll try and do what it feels like to be in a place of comfort, to be in a place of stillness and calm. So I want you to take a deep breath in, move your shoulders up close to your ears and drop your shoulders down. Move your neck to straighten out any kinks, loosen up any tightness. If you're holding any tightness in your neck and your shoulders, just move to ease that out. Now I want you to take a slow breath in and out at your own pace. Few breaths in and out as deep as you want at your own pace. With the next out breath, gently close your eyes. Focus on your breathing. With each breath in, you are breathing in healing air. With each breath out, you let the tiredness leave your muscles. You let the day's worries wash away. Each breath in brings in light and warmth all the way to the tips of your fingers, down to your toes. As you breathe out your worries, breathe out your pain. Now imagine that you are walking by the side of the sea. You can feel the sand beneath your toes. You can feel the water come and touch your toes. You can feel the cool breeze on your face. And you can feel the warmth of the sun on your skin. You can hear some birds in the distance. You can hear the laughter of some children playing in the water. You feel connected to nature. You feel nourished by the sun and the sea. Keep this feeling with you as you bring your attention back to your breath. Slow breath in and out. Each breath carrying that nurturing energy into you. With the next out breath, when you're ready, gently open your eyes. Thank you for joining me on this breathing exercise. With that, I end my talk. Thank you all.
Thank you so much, ma'am, for such an amazing session. Seriously, I think everybody would be feeling so relaxed right now.
You're very welcome. I think we have a case present.
Yeah, ma'am. Yeah, with your permission, I would like to move with the case presentation for today.
Hello, am I audible?
Yes,
Hello.
doctor. Yes, doctor, you may continue.
Good evening. I am Dr. Pratak Madan, a resident medical officer from Government Cancer Hospital, Indore. I am presenting a case of carcinoma left breast. It is a known case of TNBC with the lung mets, stage 4 disease. The patient presented us with increased breathlessness on exertion for the last 5 days, cough without sputum, which was not blood tinged for the last 2 months, weight loss, history of fatigue, anorexia, and decreased sleep for the last 2 months. History of illness. The patient is a known case of carcinoma breast with a history of surgery, modified radical mastectomy in the private hospital in December last year, followed by which the patient received radiation to the chest wall and chemotherapy in the private setup. After that, the patient was on follow-up when she developed breathlessness 2 months back. Patient initially felt shortness of breath on doing heavy work, but later on felt even on lying down and doing household chores, for which she presented in our OPD. Cough was not associated with sputum or not blood tinge. Patient has complained of loosening of clothes. On general physical examination, there was no pallor, icterus, or cyanosis or clubbing. Pedal edema was present. The pulse rate was slightly higher with 96 beats per minute with SpO2 94% on oxygen. A systemic examination was normal. On respiratory system examination, there was decreased sound in the left inframedullary area and infrascapular area with Krebs present. On percussion, dullness was found in the same area. On local examination, there was a heat scar present on the left chest with no lymph node palpable. Contralateral breast and axilla was clear with no supraclavicular node involvement. The patient was admitted in our ward for investigations and treatment. On a chest X-ray, there was a blunting of a left CP angle was seen, for which a USG chest was done to assess the amount of the effusion, which came out to be severe pleural effusion. After which the patient was counseled for pleural tapping and cytology. Patient was tapped with due consent, and the cytology came out to be malignant pleural effusion. Patient was given supportive care with appropriate antibiotics, oxygen, and steroids. After symptom relief, the patient was then discharged on oral medication. Patient again visited the hospital 1 week after with a similar complaint and was admitted again. Patient was then counseled for ICD insertion and fluoridasis. Patient was also advised for respiratory physiotherapy. In psychological aspects, she fulfills the role of housewife and is a mother of 3 children, the youngest of whom remains unmarried. Owing to her dyspnea, the patient encountered difficulty in executing routine household activities, often requiring assistance from a family member. The patient, along with the family member, is undergoing significant stress and anxiety attributed to the mother's health condition and recurrent hospitalizations. The impending marriage of a young daughter within a few weeks further compounds the emotional strain on the family. Even at home, the patient was on oxygen for more than 4 hours per day using nasal prongs. In the medications, patient was currently on continuous oxygen for 4 to 6 liters using nasal prongs. Injection pantoprazole 40 mg, injection ondansetron 4 mg IV BD, injection dexamethasone 8 mg IV BD, injection levofloxacin 500 mg IV OD, injection methylprednisolone 80 mg IV BD, tablet tramadol 50 mg twice a day, nebulization with Julin and Budecort, and high protein diet. The individual experienced a profound sense of hopelessness accompanied by perceived reliance on family member due to the illness. Dependent on the oxygen for the most of the time of the day, pain at the site of the ICD insertion, financial difficulties have arisen due to the recurrent hospital admissions, posing a significant challenge, anxiety about the daughter's forthcoming marriage, including concerns regarding personal attendance due to the ongoing health condition. 41 years old patient suffering from metastatic breast cancer with oxygen and ICD insertion. Points to be discussed: the role of morphine in the current scenario. Does the patient need palliative support? If yes, then how? Psychological counseling of the patient only, or to include the family also? Dependency in terms of oxygen support and oxygen dependency. Does respiratory physiotherapy plays a role in this patient? Thank you.
Sripriya, how would we want to do the discussion? Is it going to be that participants will come forth with their suggestions and then I'll add my inputs?
Yeah, ma'am. Like participants can comment their suggestions in the chat box, and then ma'am will also add up to that. And then we have one question in the chat box also. We can take that up after this.
Sure. I'm sorry, I got thrown off for a few minutes because of some tech glitch, but yeah. So, Dr. Preetak, thank you so much for sharing this case. A very challenging situation that you have presented from multiple aspects, right? From breathlessness, from pain management, the psychosocial element. There's some existential angst that this patient is going through. People's thoughts based on what we've discussed today about role of morphine in this case scenario. So I think we can start off with, have we addressed her breathlessness from the etiology of the breathlessness point of view? Yeah, Dr. Jyoti Vaishnav says morphine and low dose should be started. Any other thoughts? I think we've already done the counseling for a chest tube and fluorodesis, and she's probably experiencing some pain at the ICD site. And the pain relief, the pain medications she's getting are not adequate just yet. So yes, definitely, I think morphine would be beneficial in this situation. Here we have to keep in mind that the doses that we will be using will be as much to address her pain as her breathlessness. So you may need to go higher than the typical doses we use for breathlessness, right? So be open to the idea that if this was a patient who did not have a painful tube, which had recently been placed, I'm assuming with a fluorodesis, the chest tube is going to come out in some time. That if the fluorodesis is successful, then the chest tube would be possible to be removed. In that situation, you want to use the same drug, one drug which can manage the pain as well as the breathlessness. Before I go on to morphine, though, I would like to also make sure I have addressed any other treat the treatable causes. In palliative medicine, we always say correct the correctable, treat the treatable, and then go on to that. So in terms of that, have we used the non-pharmacological techniques as well, right? So have we used a fan? Have we gone through the breathing, thinking, functioning model with her? What happens? When does she feel breathless? Is she breathless all through the day, or is she breathless during some activities? Have we spoken to her about positioning and pacing? Because if the breathlessness is primarily because of an effusion, which is on one side, then are there certain positions that she's more comfortable in? Positioning, pacing, handheld fans, breathing techniques. We need to incorporate all the non-pharmacological means as well. After we've incorporated and taught all of these things, then you titrate your morphine. So you would want to start off the morphine maybe for the pain relief part of it, how much more you will need for breathlessness after you've added the non-pharmacological means. That's my take on this. When you say, Dr. Bharat Singh says, reduce oxygen dependency by counseling and lungs exercise. So when she is using oxygen for only 4 hours in a day, it's probably happening only related to hypoxia. It's only advisable to give oxygen if she is getting hypoxic. Now, you have a patient with CA breast who has a pleural effusion. If she has lymphangitic spread, so lymphangitis carcinomatosis, then it will behave like an interstitial lung disease, where she will have significant hypoxia at all times. At that time, using some amount of oxygen to maintain her saturation, at least at a level where she can maintain functionality, is important. So I never would say reduce oxygen dependency unless I know what the patient's saturation is and what that underlying lung issue is. If it was only an effusion which got drained out and now her saturation is okay, then we don't need to use oxygen. Then we need to use a fan, right? Because sometimes they say I'm breathless and they'll put the oxygen on when their saturation is 92 or 94. You don't need the oxygen at that time. But if your saturation is 70%, you need oxygen. If this patient has lymphangitis carcinomatosis, even after draining the pleural effusion, I'm still breathless because my lungs are involved systemically by the disease. So at that time, you need the oxygen. How much dose can we go up to, ma'am? Should we think of a ceiling dose with morphine in this? Because she might need high dose of morphine. So just like there is no ceiling on the dose of morphine for pain, we don't have ceiling of dose for morphine for breathlessness too. The only things we are looking out for is whether they're too drowsy and whether their other symptoms of constipation and vomiting are under control. As I mentioned earlier, usually if it's a pure respiratory case, COPD, ILD patient who has only a lung pathology, we rarely need to use more than 30 to 50 milligrams per 24 hours. Now, 50 milligrams could be a severe pain patient's one-time dose, you know. So when we are looking at pain and breathlessness, if you have a patient who is on a baseline dose for their pain management, which, you know, then you probably only need to increase it by 10 to 15% more to address their breathlessness as well. So keep that in mind, that breathlessness doses for purely for breathlessness are far lower than for pain doses. If you have a patient who's on morphine for pain who is still feeling breathless, hike up that dose by 10 to 15%, add in SOS, immediate release morphine, for anticipatory breathlessness, for mobilization, for exercise. Even for patients with malignancies, keeping them moving is always better as long as they have that degree of mobility. I think that covers the first question. Does this patient need palliative support? If yes, then how? Would anyone want to take that? To me, this patient definitely needs palliative medicine support, right? She has multi-dimensional need for palliative support. And when we talk of psychological counseling of the patient only or to include family also, I think, again, here we need to counsel both. I think even within ourselves, we see this thing of oxygen as a dependency, the visibility of it, all of that. So as we discussed earlier, we have to look at requirement of oxygen or tubes as ability and not disability. This patient's probably also deeply affected by the fact that she's got a daughter's wedding coming up. How much do the daughter's future in-laws side know about her disease? And if we can get acceptability overall that really everyone's wish is for her to be around, to be there to bless the couple who's going to start a life together, right? So it's about taking away from, moving the thoughts away from what we wish it could have been, should have been, the part of it which brings about grief and sadness, and looking at the fact of how we can facilitate her involvement without making her feel like she's a burden or a drain or a drag on what should have been a moment of celebration or a positive event in the family. So this definitely, when you want to reframe the entire story in this way, it has to be with patient and family together. So very often you might have to speak with the patient separately to understand their concerns, and the family separately, the daughter separately. And you might have to ask the patient's partner and other people that how much do the in-law side know, and how much are you willing to share, and how understanding are they of these situations that they have. Dependency in terms of oxygen support and oxygen dependency, I think we spoke about that. If the patient is hypoxic, please don't hesitate to give them the oxygen. The thinking that oxygen is something I get addicted to is not conducive to helping the patient with symptom control. If the patient is hypoxic, give them the oxygen because it actually helps to reduce the pulmonary hypertension, which will make them more breathless, which will make them more waterlogged, right? So using the oxygen for 12 to 16 hours in a day, I want them to use it for 12 to 16 hours in a day if they are hypoxic, all night long, intermittently in the daytime. So I will tell them that if going to the bathroom makes you breathless, increase the oxygen to 5 to 6 liters per minute, as much as you can tolerate on your nasal cannula for 5 minutes. Do your walk slowly with a long oxygen tubing to the bathroom, with positioning, with pacing. When you come back from the bathroom, continue to keep it at 5 to 6 liters per minute. Then dial it down. If she was at 2 liters or 4 liters, dial it down back again after 15 minutes. When your saturation has probably plateaued off at 80, 85%. Because when they walk to the bathroom, they might drop down to 50%, 43% and nearly faint. So you want them to be on the oxygen. We don't want this burden on either the patient or the family member. You want to keep them mobile. Think of oxygen as a mobility aid. So that's what I would say. Respiratory physiotherapy in this patient, mainly only breathing techniques. So you may not need respiratory physiotherapy as much as teaching them breathing techniques, pursed lip breathing, abdominal breathing, and using a handheld fan, and general physiotherapy for upper limb and lower limb mobility, for proximal muscle strengthening. So arm raises, sit, stand exercises. That's what I would suggest. There was a question of, can we think of codeine in place of morphine? Codeine, yes, codeine has been used for chronic cough, most definitely. Not so much for breathlessness. Codeine works better for cough than for breathlessness. So yeah, accessibility of codeine syrups has gone down across the country with certain changes in formulations, but codeine is reasonably good for cough.
Ma'am, there's one more question. How to reduce secretions post-tracheostomy?
How to reduce secretions post-tracheostomy. So again, we have to think of where are these secretions coming from. Secretions can be type 1 or type 2. if you have type 1 secretions are usually oral secretions which are trickling down. So is there a leak around my cuff? Checking on that. Second is if it is because of volume overload or pulmonary edema, then I need to diurese the patient more. If it is because the patient has an infection, then I treat the infection and work with nebulizations. And the quality of the secretions, if it is thick, then I might need to hydrate the patient to allow easier clearance. If it is an end-of-life situation where it's really about the sensation of secretions there's being a lot of upper airway secretions or a lot of secretions which are causing discomfort to the patient, then I will use the antimuscarinic agents like glycopyrrolate or hyoscine, scopolamine, that kind of thing. Role of ipratropium nebulization in COPD and ILD. There is a role of ipratropium most definitely in COPD. It helps with bronchodilation and with sustained bronchodilation. So in COPD, we look at ipratropium is a short-acting muscarinic agent. If the patient has COPD, then nowadays using a long-acting muscarinic agent is better. So you get glycopyrronium nebulizations. Those are useful. And yeah, should morphine be given Q4 hourly for breathlessness, or can BD also be enough? You know, when you start off with using morphine, you will, for breathlessness, very often you will find for ILD patients just that one nighttime dose and one dose timed before their physiotherapy is all they need. That's at the starting. They sleep so well through the night with their breathlessness reduced well that they actually are feeling quite okay the next morning. So you have to grade the breathlessness. It's like with a pain scale, right? You will check the breathlessness to see I'm breathless on this activity, that activity. The second thing is as the breathlessness increases. So if it's on minimal activity, if it's breathlessness at rest, then you will go to a Q4 hourly dosing, which you may choose to hold if the patient at that time says, I'm not feeling breathless. So in breathlessness, your morphine administration through the day is more on an as-needed basis, as opposed to in pain management, where you never want them to ever peak on the pain and you're giving it to them Q4 hourly all the time. So you can work with slightly reduced frequency of administration for breathlessness as well, unlike with pain. So we start off with BD doses, and then it might go to TID, depending on, okay, breathlessness on walking. I need to walk there. I need to go there. So I'm going to take the morphine and then go ahead and do wherever I need to walk to do whatever action I need to. My take on Lasix, IV or nebulization in breathlessness. IV Lasix definitely useful. Nebulized Lasix not as effective. I know that it is one of those drugs which can be used as a nebulization, but really if you have a person in volume overload, the nebulized Lasix is not going to do as much good as an IV can. So that's what I would say about nebulized in breathlessness. In breathlessness, you will, you use your standard bronchodilators if the patient has wheezing. So that's going to be your short-acting bronchodilators will be your salbutamol, levosalbutamol, or your ipratropium. If the patient has known COPD or asthma, then you would also use the inhaled corticosteroids, which would be a budesonide or fluticasone or any of those.
Ma'am, there was one more question regarding the role of cough syrups.
Role of cough syrup. Role of cough syrups is mainly in acute coughs. So when you get these 3 to 5 day coughs with viral infections and things like that, that's when your role of cough is. Because if you look at what's in that cough syrup, you will see a combination of an antihistamine. You will either see a mucolytic or an expectorant, or sometimes you will see antihistamine with a cough suppressant, right? So it doesn't really address the issue of the underlying pathology. It's meant to look at dry cough, wet cough, whether it's a viral or a bacterial infection or an allergic cough. So it'll only help you for those 3 to 5 days. But if you have a patient who's got ILD, who's got cough continuously for 5 years, that cough syrup is going to do nothing. One more part that the cough syrup does is the demulcent action, right? So it gives you that sticky layer where the dryness of the upper respiratory mucosa is alleviated, the irritation is less. All of these things, but along with it, you also have whatever is your vehicle in the cough syrup. And these patients, sometimes you will also have things like terbutaline and all kinds of things put into the cough syrups, and then they'll be coming with palpitations, tremors, and all of that. So I really do not like using cough syrups. There used to be a plain cough syrup of codeine that is effective for these patients with chronic cough due to interstitial lung disease, or some of the cough because of, even sometimes if you have an airway stent or an airway tumor which is causing irritation within the airway. Which drug to use as an antitussive in patients with cough during radiation therapy? You could try, so if it is because during radiation therapy, or is it as sequelae of radiation therapy? If it is fibrosis as sequelae of radiation therapy, sometimes it is because of, so one drug which I didn't mention is benzonatate. Benzonatate again decreases the sensitivity to cough. It's a very hit or miss drug. It comes as a capsule called Benz Pearls. So some patients feel good with it. They find their cough released almost 50% by benzonatate. We usually give it as 200 milligrams 3 times a day for an adult patient. Comes in 100 milligram capsules, so 2 capsules 3 times a day. It can be used for stretches of 7 to 10 days if you need it. Otherwise, the other drug which helps is when we looking at suppressing the hypersensitivity, and that would really be the gabapentin. So think of it like how you look at neuropathic pain. It's the neuroreceptor pathway that you're looking at decreasing the hypersensitivity to cough. So if it is because of fibrosis and constant stretch that the patient is experiencing of the interstitial lung disease, then the gabapentin might help you. And it's really a therapeutic trial. You try it out and see. If the patient's not feeling better in 1 to 2 weeks with your intervention, then don't continue the medication, because polypharmacy is something we want to avoid in these patients. And in that case, then morphine or any opioid, codeine, morphine then becomes the alternative. I will tell you that cough can be a very, very, very distressing symptom. I have some patients who have GI problems as well as psychiatric problems from eating disorders, and they have chronic cough which is incessant, and the only way of controlling the cough is to sedate them for most of the day. So we don't realize how big a problem it can be. Lidocaine jelly, viscous lidocaine. Viscous lidocaine can help if it's primarily an upper airway cough. So if you have any condition which causes a lot of upper airway hypersensitivity or stimulation, viscous lidocaine can help. But also keep in mind that aspiration precautions, because if it's numbing up the throat, then you might also be aspirating. So only for short-term use, it's not a long-term use intervention.
Participants, any more questions? I think we have only 3 more minutes, and I couldn't find any more questions in the chat box. I think everything was dealt with already. Thank you so much, ma'am, for such a wonderful session.
Thank you for inviting me, and thank you to all of you for, being around for this conversation. I hope it was helpful to you, hopefully for your patients. And if there's anything, you know how to reach me. Shri Priya will connect you, or Dr. Hashmat will connect you to me at any time.
So, Dr. Hashmat, would you like to add any closing words?
No, I think it's over and there are no more questions. Over to you, Shri Priya.
Thank you, Dr. Rajani, for that breathtaking session on breathlessness.
Thank you.
And I believe that at least some of them would have got a really inspirational evening today. Thank you so much for joining us, and we do really look forward to have you in more sessions in future to enlighten us. And thank you everyone for joining in and making the session interactive as usual. So with a promise that we'll be meeting again in the next session with another interesting topic and yet another eminent faculty. This is Sri Priya along with Dr. Hashmat Farhana and Dr. Rajani Bhat signing off from the Tips Eco Hub. Till the time we meet again, everyone stay safe, stay connected. Take care, bye-bye.